I'm going to talk about a project that I'm working on with some collaborators at Cincinnati Children's Hospital in sports medicine. And we're trying to develop a theoretically motivated intervention to reduce ACL injury risk. ACL injuries obviously are a very serious type of injury and unfortunately a very common sort of injury that entail a lot of significant cost, economic cost, as well as pain and short-term pain and suffering on the part of the poor souls who suffer them. And it's also associated with a pretty substantial increase in risk for osteoarthritis, which might start showing up if a 12-year-old tears an ACL. By the time they're 22, they might have pretty serious knee osteoarthritis. And that can lead to long-term loss of mobility and additional health complications that might be associated with that. So given these consequences, there's a recent emphasis in trying to prevent ACL injuries rather than merely treat them after they occur. And it's known that there are risk factors that are associated with ACL injury risk, and that these risk factors are modifiable. They can be improved. So for example, and you'll thank me that I cut out the third panel of this figure, which showed this person's knee collapsing in a really grotesque manner. She has just landed from jumping, and you see a number of the identified risk factors occurring here. There's trunkling, there's asymmetric loading of the weight on the 2 feet, and this valgus angle of the knee in particular is a really serious ACL risk factor. I'll change the image now, Mike. You don't have to watch it anymore. So the interventions that have been developed are in principle effective, but they've not been ultimately very effective in actually reducing injury risk. And there are a number of reasons that these haven't had the impact that we might hope. The interventions are very expensive in terms of time, financial cost, and labor. There are problems with getting athletes to adhere to the programs, to comply with the intervention exercise routines. But really one of the major problems that's been identified are problems associated with presenting feedback to a subject, to an athlete, that's usable, that can help them modify their movement patterns and reduce their injury risk. In most ACL intervention programs that have been developed, an athletic trainer is working with the athlete, and they're telling them things like, reduce your valgus angle, or increase your knee to hip moment ratio. I don't even know what that means. How can you give feedback in a way that an athlete can actually use it to improve their movement patterns? So that's what we've been working on with my colleagues at Cincinnati Children's. And of course we know that feedback, knowledge of results, generally speaking, can improve movement patterns, movement performance, especially through the work of Gabby Wolf and colleagues when the feedback directs one's attention toward the external consequences of movement. But the sort of work that sort of inspired our approach here is work showing that if you map or remap complex actions onto relatively simple feedback displays, that this promotes learning that is rapid, robust, and transferable. The work by Mexner and colleagues is an example of this type of strategy of mapping feedback from a complex action into a simple, in this case, visual form. Many of you are probably familiar with this study. The subject's task was to produce a 4:3 frequency ratio by moving these little cranks around. If you tell someone to make a 4:3 pattern, it's damn near impossible to do. But in this study, they remapped the movements onto a visual display such that a 4:3 pattern of movements with the hands produced a 1-to-1 pattern of movements of little dots on the screen. And when they did this, subjects very quickly were able to produce a very complex movement pattern. This type of strategy, of course, is sort of building on or stems from the very notion of perception, action, and reciprocity with which many of us are familiar. And it suggests something like what the subjects are doing in a task like the Mexner et al. Task is that they're controlling perception. They're acting so as to produce a certain perceptual outcome. Like we see with Gibson's rules for controlling locomotion, how do I steer toward a door, as Bill Warren showed us, move so that the focus of expansion is centered on the object or to the location where I want to go. I act so as to control perception in some sense. Another example is the work of Elise Folgoire and colleagues, Ben Bardi, where they had subjects produce hip-ankle relative phase or coordination patterns, and they didn't really explicitly instruct the subjects move in phase or move anti-phase, but rather they instructed the subjects to move so as to draw a diagonal line or a circle on the screen. So the subject had to discover how their movements mapped onto this display, and they were able to relatively quickly learn these sorts of patterns. And in a really interesting study by Deborah Veraki and colleagues, they showed that when this was used as an intervention for stroke patients, it produced sustained improvements in balance performance. So with these sorts of studies in mind, we developed the following sort of program. And this is, I don't like the term neuromuscular training, but this comes from the sports medicine literature. But I came up with a clever pronounceable acronym, so I feel like I could retire now. We call this ANIMATE, Augmented Neuromuscular Training. So subjects are outfitted, for now, outfitted with motion capture markers, and we have them perform some pretty standard, fairly simple tasks. In this case, it's a squatting task. We're recording their movements in real time, and we are presenting those movements in this sort of display. So the subject's task, we tell the subjects move so as to try to keep this shape rectangular. And every time I use a laser pointer, it stops the video. Move so as to make that shape a rectangle. Move so as to make that shape a rectangle. So they're viewing this through a little head-mounted display. This is moving in real time. Maybe about a 10 millisecond lag, as much as is about what we are estimating. They see the shape in the glasses, and and they don't know what's driving this display. I'll explain that in just a moment. But the variables that are driving the display, it's an assortment of 6 biomechanical variables that are related with ACL injury risk, those modifiable risk factors that I described, that I mentioned earlier. Okay. Here are those variables. Trunk lean causes the shape to lean left or right. The knee to hip moment ratio, which we can't ever explain to athletes in any intuitive way, is just related to the size of the square, and that was actually not shown in the video I just showed you, but it's implemented now. So they're trying to make the rectangle large and rectangular. The knee abduction moment, this sort of valgus, this pinching or bowing out of the knees, controls the location of the midpoint here. The vertical ground reaction force ratio shifts the rectangle in this direction. And for the static squat tasks, these are not so relevant, but for more dynamic tasks like a repeated tuck jump, we can have foot placement or foot width and landing position added to the display as well. Right, so these are being computed in real time and used to drive the display that the participants or the athletes see through the sort of smart glass. I'll present to you the results of a preliminary study. We're following up on this now, and we have some other plans that I'll describe in just a moment. We looked at 10 female athletes, high school athletes, who had already gone through an ACL injury prevention program. Athletic trainers uniformly agreed that these were among the best of the athletes who had gone through that training. So we were almost setting ourselves up for failure here because they were already pretty good at performing movement patterns with a low-risk profile. Yeah, some details you don't really need to know that much about. We did a pre-test and a post-test of the squat movement. And during the pre and post-test, they were not watching the real-time displays. And there were 4 training blocks of 10 squats. So this is a very minimal intervention. And during those blocks, they were tasked with trying to move so as to create a rectangle. So a very brief intervention. Here's some results. I'm going to talk about some individual subject results and then some group results. And I'm going to talk about what I'm referring to as the local biomechanical variables as well as a more global measure of performance. So these are individual subject data regarding the local biomechanics. There's a lot of stuff here. You have to trust me. If you listen to Mary Lauren's talk, you might not trust me, but essentially what we found were positive adaptations or improvements toward a lower injury risk for both kinematic and kinetic variables associated with the knee and the hip. Basically, they were squatting deeper, so increased hip and knee flexion in the post-test, drawn in blue. And they were achieving that essentially with a lower hip flexion moment, and the knee flexion moment was not really as clear. But these are, my sports medicine colleagues tell me, the kinds of adaptations they hope to produce through these interventions. Here's one really key variable, that knee abduction moment, the forces on the knee, that valgus varus pinching in aspect of the movement. This was significantly reduced during the second half of the movement phase. This is one of the variables they worry about quite a bit. It's a very sensitive and specific predictor of ACL injury. This is kind of a cooler way to see the data. This is effectively redrawing the stimulus shapes that they produced during the 10 consecutive squats in the pre-test and post-test, where there, once again, I'll remind you, no display was active, and then during the 4 training blocks. So the warmer the color, the more amount of time the shape occupied that region. Does that make sense? So essentially what you want to see is a nice red rectangular shape here. It's a little bit challenging to see. Can we get the lights dimmed in the front again? It might help. Yeah, it's a little better. So this is the pre-test. This athlete, once again, who had already gone through training and was judged sort of visually by the athletic trainers to be pretty good, was really showing a pretty pronounced deficit at the, I think that's the left knee. I think we're looking at these as if we're in front of the athlete. The left knee. Over the course of the training blocks, and then in the post-test, when once again no feedback was present, you see overall improvements in performance. Another way to look at this improvement in performance is to essentially subtract this shape from this shape. That's what we have here. This shows the percentage of change from pre to post-test, or really the post-pre change. So we really were able to induce a lot of change in that critical biomechanical variable, as well as the vertical ground reaction force asymmetry and trunk lean as well. This was, for my colleagues in sports medicine, a pretty shocking improvement to elicit through 40 squats. So we're very, very encouraged by this, and so was NIH, thankfully. Just to sort of kind of tie things together and point toward where we're going, I'm really excited about this project because it's finally sort of one project where I'm able to really use some fundamental principles about the reciprocity of perception and action for a really important practical problem. So it kind of couples theory and application very nicely. Yeah, some other stuff up there you don't need to read. Our preliminary study was effective, and a really important point was that the task was really intuitive for the subjects. When they're getting barked at by an athletic trainer, they don't enjoy doing the exercises. They don't often understand what the athletic trainers are trying to tell them. These are 12 to 16, 17-year-olds. You know how they are. They don't want to be barked at by an athletic trainer, even though they're very motivated athletes. They don't want to have an ACL injury, but still, they generally don't like the training interventions. They actually liked this. It was engaging, had a lot of technology. It was kind of like a game. So we're hoping that athlete compliance will be a little bit better as we progress. And we're also looking I think just a few years down the road, we'll be able to do this with wireless motion capture that can be used indoors or outdoors, and it's highly portable, so it'll really make this a cost-effective intervention as well. So we are now hopefully about to start a 5-year clinical trial where we'll have 12 training sessions spread out over 6 weeks, a variety of different exercises, and we're going to do assessments to try to determine if these movements transfer, if they're retained and transferred to more realistic movements. A drop vertical jump and a cutting task, as well as a sort of version of a jumping task performed in an immersive virtual environment. So we have these scenarios set up for rebounding a basketball, heading a soccer ball, blocking a spike in volleyball. And this is what my colleague Adam Kiefer has been working on at Children's in his virtual reality lab. And we also have our sort of control group, this sort of sham protocol, where the sham display doesn't really produce any useful information. This is the real display, as if we were really faithfully mapping their biomechanics onto the shape. This does so for about this much of the movement, right at the top of the movement. But as they get deep into the squat, where the biomechanics are really important, the display is being driven more or less by just random noise. So, yeah, that's where we are. Thanks very much.